All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, as usual, with rock star guests, we are here once more. Time early in the morning instead of the evening. So, today we have two rock stars from Dr. Marc A. Levitt's office. We have Julie and we have Katie with us. They would help us understand bowel management today. So, why not we start asking them about themselves and then the topic? So, welcome to both of you.
Thank you. We're excited
Thank
to
you.
be here.
Excellent. So, how about we start with Julie? So, Julie, tell us a little bit about yourself, your day-to-day work. What are you working on nowadays? And then we'll ask Katie about her activities.
You bet. Well, I am excited to be a part of the colorectal program at Children's National Hospital in Washington, D.C. I came with Dr. Levitt in 2019 specifically to set up a program here at this hospital for children with all types of colorectal conditions that we'll talk about as we go through our time together today. But I worked in Columbus, Ohio with Dr. Levitt for several years, building a center there. And then we found that there really wasn't any care for these children on the East Coast and the eastern seaboard of the United States. There wasn't a comprehensive center like we had envisioned for them and how we had built in Ohio. So we moved here together with our families and were able to set up a center here. My background is in nursing by trade. I'm an emergency medicine nurse and found myself very intrigued by the work he was doing at the hospital in Ohio when I would work with nurses that I trained and educated in the inpatient unit, and found out more and more about his program and became very attracted to it, and then moved over to helping him with that program there. So I'm excited to have built a program here. And we have an exceptional team here led by Katherine, who's on the call, and she's going to introduce herself to you now as our clinical leader.
Awesome. Thank you very much. So, that's a great segue. So, Katie, tell us about yourself.
Sure. So I'm a nurse practitioner, certified about 9 years ago. I started my career with a general surgery team. And after about 4 years with them, started taking over bowel management for their specific patients. So patients who had Hirschsprung's or anorectal malformations and such within our department, I then took over to my clinic to help them with their bowel management issues. And then in 2019, so 2 years later, Dr. Levitt came to Children's National, where I had been working. And then I was blessed with the opportunity to join his team and expand our services to patients internationally and worldwide, which is awesome.
Awesome. Thank you very much. So, as to the audience, as I said, we have rock stars here, and here they are. So, the topic today, bowel management. Are we talking about, and let me ask this question from Julie first, are we talking about bowel management before surgery, after surgery, and what is bowel management? And if you like, I can bring up your PowerPoint as well, and if you want to use that. But really, the question, what is bowel management? What are we talking about today?
Sure, that's a great question. What is bowel management, and when would a person, a child or adolescent or even an adult, when would they go through a bowel management program, or what does it mean to go through a bowel management program? Those are the things we're going to share with you today. And it's not always a surgical program. We do see patients that don't ever have surgery, which is unusual for a surgical center such as ourselves, but we will help patients with their bowel management even if they don't require surgery. Some do require surgery, and then there is care after that surgery. So it's a perfect segue into leading me into our presentation here today. That's just a quick look at our hospital. In the atrium, there's these beautiful hot air balloons. It's a pediatric hospital in the United States, and we try and keep it very friendly and patient focused. So it's a cheerful place to be. What does it mean to be bowel management? Well, when we think about good surgical outcomes, we have to think about time spent outside of the OR. And Marc Levitt, our division chief and leader, says that for every 4 hours in the OR, 96 hours of nursing care are going to be needed to help the patient be successful and truly produce a good surgical outcome. And so that's kind of why we're here today, to talk about the care before or after that surgery, if there is a surgery, to share with you what's needed for a good bowel management outcome. And you're going to
Got
hear
it.
us refer to Dr. Levitt as Marc. At our center and at many hospitals here in the United States, we refer to each other in first names, regardless of our roles. And we believe that this familiarity fosters an environment where all voices are equally important in the care of our patients. And we know that literature supports that type of culture and that it shows to directly impact a safer patient care environment.
Got it. And thank you very much for this. Just
Yeah.
a quick note for the audience here. Audience, Cool Beans, if you have a question, please make sure that you put some sort of a marker with it, for example, QQQ or question marks, so that I can find those within the comments and ask your questions. Otherwise, it is difficult to read every single comment to figure out where there may be a question. So thank you very much for some housekeeping. Back to you, Julie.
Great. So what is bowel management, right? You hear that term, but what are we going to talk about today? Bowel management, as it says right here, is just a way to control the colon and keep the patient continent and accident-free. What does it mean to be continent? When we think of being continent, we think of being clean. So we want our children, our adolescents, our adults to be able to go out into the world and do all the things that all of their peers are doing without worry about soiling or being distended or uncomfortable or constipated or any of those things related to the bowel. We want them to just go out and enjoy life. And what kinds of populations do we help with bowel management? Well, we look at children and adolescents, adults that have anal rectal malformations or ARM patients, patients with Hirschsprung's disease, patients with functional constipation, or patients that have spinal anomalies. And for functional constipation, that's a new term for some people. They're used to hearing it called idiopathic constipation. And the word idiopathic kind of means we don't know. But we do know. We know that the colon is there. It's normal. It's functioning, but it's very slow moving, and that can cause problems.
Got it. And in this context, just a quick question from
Sure.
Casey. She said, does your center have a bowel management program for adults?
That's a great question. So we currently are we are pediatric providers. Our nurse practitioners, our surgeons are pediatric by nature, but we are excited to be offering a transition program, which means that we can see adult patients, we can initially meet with them, and we have partners in our adult hospitals nearby that work with us as a partner so that we can transition the patients from our center to theirs, but with our expertise in bowel management, because we know that for the adult world, a lot of people are lacking that partnership, right? They're lacking that adult relationship with their provider, and they may not have a lot of knowledge about bowel management. So we're happy to
Got
be able
it.
to help adult patients as well.
Got it. Thank you.
Mm-hmm. So the first thing we have to look at with bowel management is, what is your potential? What are the chances that you're going to be able to be continent and be like your peers and not have any problems? And there's different categories of patients that we talked about. And we're going to talk about what we need to look at in order to determine whether or not those different populations are going to be continent. We know that all of them, we're going to look at their anatomical evaluation. We know that we're going to look at whether or not they're at a realistic age for potty training, because sometimes people will be talking about continence with a 2-year-old, and we just can't do that. We want to wait until they're at an age appropriate level for potty training. And then we know that we're going to need a motivated patient and a motivated family, right? We are nothing without our partners, and our partners are our parents, and our partners are our patients.
Got it. And if I can very quickly respond to Franco, my suspicion is that this topic cannot cover this question, but I'm going to ask it anyways.
Sure.
So Franco says, what can you do to improve IBS apart from supporting SCF production, probiotics, prebiotics, reduce stress, avoid FOD, MAPS, take FOS, etc.? So
Yeah.
again, if it is out of context with this one, please tell us. If the answer is coming down the road as well, that is good too. So
I mean, I think you'll hear some things down the road that might be think of this as a smorgasbord, right? It's a buffet. We're going to give you a lot of information, and you pull the information that's applicable and meaningful to you and leave the rest of it behind. All of it's not going to fit your diagnosis or fit your patient population that you serve if you're a provider, but some of it will. We are not going to get into what was the underlying condition? I'm sorry.
IBS.
IBS. Yeah, we're not going to go into IBS too much, but it doesn't mean that some of what we say won't be helpful to you.
Got it. Thank you.
You bet. So the first patient population that I mentioned was patients with anal rectal malformations, and we call that ARM. And when we look at these things, we're going to look at three things. We're going to look at the type of malformation that the patient has, and listed there are some different types of malformations. We're going to look at the quality of the patient's sacrum, and we're going to look at the quality of the patient's spine. And you can see that the diagnoses there are not a one or done. It's not either or, right? It's a continuum. And we find that these patients slide back and forth somewhere on this continuum. But we do know some things. We know that the more complex the malformation, such as a cloacal patient with a long common channel, we know that they're going to have a poor prognosis for bowel control. And so we want to be realistic with families. We don't want to make it sound like it's going to be a walk in the park if we know we're up against a lot of work. But we always try. And we always feel like we can somewhat improve the lives of our patients. That's our goal.
Got it. There is a quick question here, and I suspect the answer may be down in the presentation as well. Ashish Chaturvedi says, and apologies for mispronouncing if the name, some old patients have a regular constipation issue. They keep doing many things. What best can be done with more continuous and regular results?
Great. We're going to go through that. We're going to get to that, especially with functional constipation patients. And we'll be able to give you specifics for that population and for that,
Excellent.
that
Thank you.
challenge.
Thank you.
So our predictors of bowel control are anal rectal malformations. We looked at that. We're going to look at the quality of the sacrum and quality of the spine. And with the quality of sacrum, we use something called a sacral ratio. And this is for the medical providers, just how we calculate that sacral ratio. And you can see that it is a slide from poor to good for continence. And this isn't a standalone, right? We're going to consider this along with the type of malformation and the type of the spine. But it is one of the three components that leads us to be able to calculate what we think their predictor for bowel control is. And here you see that less than a 0.4 is a poor indicator of bowel control, while greater than a 0.7 is very good. And for the providers on the call, it is important that when we look at these x-rays, we utilize the lateral view for our slides for our x-ray, because you do get a pelvic tilt on the AP view. So we don't use the AP view. And you can ask your radiologist when you're ordering this to give you that view. And then the last component of this predictor for the anal rectal malformation patient is the quality of their spine. And on the left, you're going to see what we want to see, which is a normal termination of the conus with a normal spine ending between L1 and L2, as well as a normal phylum appearance. And then, unfortunately, the patient on the right is going to score much lower. They have a tethered cord, they have a low-lying conus, and that fatty phylum is present. So that's not going to be as good of a predictor of bowel control for that patient. And then we take all three of those things, that anal rectal malformation type, the quality of the spine, and the quality of the sacrum, and we actually put it all together out there on a report card and share that with the families. And we tell them, this isn't the be all end all of everything that's going to happen, but we want to make sure we give you realistic expectations. Some patients Marc will say, you get an A, you got the best thing you can get. You got an A. We're not going to have any problems. We know this is going to be easy to do. Or they're going to be down there in that 7 to 9 category, and it's going to be hard. So we're going to give you a little chance now to see what you know and what you've heard, and see if you can help figure out this patient's continence indicator. Katie's going to walk you through this.
So this is an example of a patient who may walk into our center. But a child comes in with a rectobulbar fistula. His conus terminates at L1 on a spine MRI. And you can see here his sacral ratio is calculated to be 0.54. So then we want to be able to have a conversation with the family about what is our prediction for his continence long-term. So just give you a second to read through those answers. But at the end of the day, we're going to discuss with the family that this child actually has a pretty good potential for continence, that we should be able to get him on a good bowel regimen fairly easily. His malformation, the rectobulbar fistula, is fairly low, which works in his favor. And then he has a normal spine. His sacral ratio is 0.54, so less than 0.7, so not ideal, but still between the three factors that we're looking at, think he has a really pretty good potential for continence down the road.
Got it. Thank you.
Okay, so then the next diagnosis that we frequently see are those with Hirschsprung's disease. For Hirschsprung's disease, we're going to look at three different factors to determine whether or not, or how good of a potential they have for continence. And the first one we look at is their dentate line. The dentate line is within the anal canal and allows the patient to be able to differentiate between if they're sensing the presence of gas or stool. So in Hirschsprung's disease, when they have surgery, sometimes this dentate line can be damaged or it can be completely removed. We know after experience and from literature, it shows that by dissecting 0.5 or 1 centimeter above the dentate line, you can protect it and preserve it. But if we see a patient and we find that the dentate line is absent or damaged, this is going to have indications for how well the patient's going to do long term.
And Katie, just a quick question, and I think it is in context of the question from Ashish here. And the question is that other than neurological issues, age changes can also cause this. So how best can we stimulate to get best outcomes? So I think the question is are you going to discuss how to manage this as well?
Yes. And we have found that actually patients with a damaged dentate line can have good bowel control as long as their sphincters are intact, which is what I'm going to talk about next. But even with damaged sphincters and a damaged dentate line, there are options that we can lead a family through in order to offer social continence.
Got it. Thank you.
Yep. So the next indicator that we look for with Hirschsprung's disease is whether or not their sphincters are intact. Do they have the ability to squeeze those sphincters and relax them on command in order to provide the patient with better control? And then lastly, we look at their colonic motility. So how fast or slow does stool move through the colon for these patients? And I think most people identify that Hirschsprung's disease patients are prone to constipation or being hypomodal, but we actually have a handful of Hirschsprung patients who are hypermodal, and actually the stool moves very quickly, particularly in those patients who a large portion of their colon is affected by the disease. And so we have to figure out the motility for their specific patient and then what treatment options we can use to customize their care. The other diagnosis that we frequently see is functional constipation. For these patients, we're going to look at their anatomy. For the most part, it's typically normal. Sometimes they have a dilated colon or some redundancy in their colon, but they're normal. Their anatomy is otherwise normal. We're going to look for colonic dilation and their motility. How fast do they move stool throughout the colon? And is it throughout the whole colon, or do they have segmental issues in different spots of their colon? And then we want to make sure that we're aware of any behavioral components to their care. A lot of functional constipation patients have withholding behaviors where they purposefully try to withhold the stool. And so we need to also address that and work through that with the patients and the families. And then the last group that we see frequently are those with spinal anomalies. These are those with neural tube defects, which includes the spina bifida patients, sacrococcygeal teratomas, tethered cord patients, caudal regression. And for all of these patients, we're going to be looking at their nerve innervation and then be aware that many of them also have underdeveloped sphincters, which is going to make it bowel management more challenging.
All right. So our bowel management program. So when we've figured out their continence predictor and whether or not we think they're going to have an easy time or a difficult time, regardless, we want to put them in a program. And this program lasts for over a week. So it takes some time. It's not just like one and done. We do daily changes and we need to see what's working and what's not. And even if we're achieving the goals we want, whether or not the patient can tolerate what we're prescribing. So that's very important. During that week, we have some key items that we know need to take place. Before we even start out, we're going to get a contrast enema. to evaluate the colon and the rectum. We're going to look for things like, is there a Suave cuff? Is there a Duhamel pouch? Has this child been operated on or treated in some way that has left us with something else that we have to worry about or work around? We do an exam under anesthesia. Now, in the adult world, that might not be done under anesthesia, but for children, we try and do trauma-informed care, which means that we're not doing things that are traumatic to a child. We want to make sure every interaction they have with us is pleasant and goes well. So we do that under exam under anesthesia. We don't do those physical exams in the office, unless it's a very, very young baby that we know it's not going to be traumatic for. Otherwise, we'll move into the OR and do that under a little bit of anesthesia. Most children are what we call anally defensive. And we always joke, who isn't anally defensive, right? But they don't want to have someone examining their anus. So we want to make sure we keep that trust and that cooperation relationship intact. So that's why we do that under anesthesia. And then daily, the child's going to get x-rays for the 6-day week that we have bowel management. And our nurse practitioners and physician assistants are going to assess the stool burden each day and response to treatment. So how is that stool burden responding to the treatment they're prescribing? We will see them in clinic 3 times during that week. But even between their clinic visits, like I said, they're getting those x-rays and they're communicating with our team on a daily basis. They'll fill out a report card type log that we give them a whole binder or manual to keep. And they'll write down responses to treatment, side effects, compliance, whether or not the parents could do it, whether or not the child was willing. And we'll make changes every day. Our nurses, our RNs, are the ones with the eyes on the patients. They're the ones communicating with the families through email. And then they're answering the questions they can to the fullest scope of their practice. And when they need to tag a nurse practitioner or physician assistant, what we call a mid-level provider, they can interpret the x-rays and then prescribe medications based on what they see. But we really utilize our nurses heavily during this bowel management week. We kind of call them the draft horses.
I think we have a slight interruption from Julie's side. So in the meantime, while Julie's program comes back, Katie, can I ask you a question?
Sure.
There was a question from here. Pamela Covington says, how can I get on this program? I have so many bowel issues. So again, adult versus child. And if somebody who's an adult comes over, how do you manage them? How should they contact you? How do you manage them?
Yeah, so our patients are often self-referred. They reach out to us by finding Marc Levitt on the internet and reading about him and wanting to, have him care for their child or for themselves if it's an older patient. They will reach out to us. His email is actually published on our hospital website under the colorectal program. And they can reach out to colorectal, one word, colorectal at childrensnational.org. And that puts you in touch with our administrative team members, and then they can get the ball rolling for people that way. So if you want to type that in the chat, you're welcome to. It's colorectal at childrensnational.org.
I actually just copy pasted the link.
Great. Thank you. But we do believe in educating and working with our parents as partners and our families as partners, because we don't want to extract people from their local care and then they go home and they don't have anyone to lean on and they don't know what to do. So we're very big into education, and psychosocial support groups are really important. There's a lot of online psychosocial support groups, but we believe that that's really important, that you need to have emotional support. These are not heart patients. These are not diabetics. These children, they're not going to be running around telling everyone in the neighborhood what their problems are. So we really feel like we owe it to them to give them good psychosocial support while they're with us. And we do have a psychologist that's joining our team in July, so we're very excited about that.
Thank you very much.
Yeah. The next thing to come into our bowel management program, what are we going to do? Are we going to give you medications that you can get over the counter? And we're going to talk about those because there's a lot of those. Or are we going to do something what we call mechanical, which is another way to help you empty your bowels? But again, the goal for everyone is to be clean, right? So that they can wear normal underwear like other children and play all the games and do all the activities. And the high schoolers can be involved in sports and go to the pool and do sleepovers and all those fun things without worry. So that's our goal always. We have
Got it. And once again, for clarity,
Mhm.
Hamila says, is this for adults as well?
Yes. So again, we're a pediatric hospital and we are treating children and young adults under the age of 21. We are working on a transition program now. We do have partners in the adult world who we can refer to that can help with the care as well, that are more well educated because of their relationship with us than perhaps others.
Got it. Thank you.
Yeah, you bet. So considerations, how do we know which way you're going to go, medication or mechanical? All of these components you see here are very necessary. We already discussed the potential for bowel control. We have to look at that. Again, we do those contrast enemas, that exam under anesthesia to look at the anatomical evaluations. Sometimes we have to ask if a redo surgery is necessary. What conditions are things like the dentate line and the sphincters that Katie talked about? Is there a really dilated or redundant colon? Has it been damaged? So that potential for bowel control along with the anatomy are very important and probably are key features that we have to take into consideration first. Then we look into things like developmental considerations. We have patients with autism or sensory integration issues. They're going to tolerate some things differently than another child might. So we're going to make sure we're keeping those kind of things at the forefront of our thoughts as we prescribe and plan. And then family adherence. It's interesting, you know, we think we know what a family's going to want or a child's going to want, but sometimes we don't. Sometimes our goals are very different. So we need to ask, what are the patient's goals? What are the family's goals? Do those two things align, right? Do the patient's goals and the family's goals align? And then is that what we think is that we can achieve and what might be best for this patient? Sometimes we find that, you know, we think they're going to want to take medication because they're a teenager and they're not going to want to have to do an enema or a mechanical option. They're going to want to take a pill that no one knows about. But the benefit we see with the mechanical option is the reliability, right? The time voiding. It's very concrete. They're going to sit on the toilet at this time. They're going to empty their bowels versus a laxative that may kick in, you know, over a period of a couple hours. There might be a window of time there. And perhaps your teenager wants more predictability than they do necessarily to take a pill. So we just need to make sure that we're really talking to our parents and keeping and families and patients and keeping a good conversation going. And that's really true with anything in medicine, right? The doctor and the patient really need to, or the provider really need to be on the same page about where they're headed in order to produce the best possible outcome.
Absolutely.
And so now I'm going to walk you through that medication program. And these are over-the-counter medications for the most part, so something that anyone can get their hands on. But our goal is to mechanically and effectively clean out the colon. I'm sorry, the mechanical program. And we do this two different ways, either with a rectal or an antegrade option. When you think of rectal, you can think of things like enemas. And antegrade, you think of a surgical intervention called a Malone or a cecostomy. And we give a flush through the enema or through the antegrade option. And the rectal enemas are what we give. And either way, the goal is that we have no bowel movement beyond the flush. So once a day, they're going to be doing that flush either through their enema or through their Malone site, and then empty their bowels and be done for the day and have, you know, no soiling, be able to be continence, be in clean underwear, just like every other child. And we pick the superhero picture of underwear because that is how they feel. When they finally get clean and dry, they feel like they're the superheroes and they can just be normal kids. If we go with an enema, a rectal enema or an antegrade option, parent education is essential. We use videos to teach our parents along with hands-on training with our nurses. We like to keep the timing of the flush and of the enema the same every day so that we're measuring the same amount of stool load each day. When the nurse practitioners and the physician assistants look at those x-rays, we want to make sure that they're comparing apples to apples so that they're looking at the same thing every day, the same stool load. We use something called a Coudet catheter, and if you're not familiar with that, it's a catheter with a little curved tip at the end. It's more easily inserted, and we use that as part of our antegrade flush in the Malone or cecostomy. We will place the 24 French Foley into the rectal portion if they're doing a rectal flush, and that's important because it has a nice balloon that inflates, and that balloon allows the solution that we infuse to stay up in there and where it's supposed to and not leak out until it's time to release that balloon and let it flow out. And then I mentioned we'll get an x-ray after that. We'll get it the same time each day so that we can see whether or not we're accomplishing our goal of cleaning out the bowel.
Got it.
And what do we put in that, right? So what do we put in that solution that we're either putting in through the belly button, through the Malone appendicostomy, or up into the enema? Well, we use a few different ingredients here, and they can be mixed and used together or standalone, depending on what the patient needs. We always start with a base volume, which is saline. We use saline. We are reevaluating that, and for children who are greater than 3 or greater than 10 kilos, we are not as worried. We can go ahead and use water for those children. But for the younger ones and the ones who weigh less, we use saline. And then some patients will get a stimulant laxative here, or a stimulant like glycerin. But sometimes that can be a little bit agitating and cause some side effects that kids don't tolerate well. And in that case, we can start looking at something a little softer like Castile soap or baby soap, which is important if your family can't get glycerin either. They can usually always find the Castile soap or the baby soap. Sometimes we will add that in with the glycerin. When we've maxed out on our maximum density of glycerin, we'll start to add in something else. And then the third kind of line that you see there is bisacodyl. Bisacodyl came to us from our partners in a GI team at our hospital, and they were using that for motility testing. And so we did add it in, and we have used it on some patients. But it is a great example of how when you start to talk with other areas of the hospital and providers, you might pick up on some ideas that you wouldn't have considered on your own. You kind of never know where the next successful component to care for your patients is going to come from. We do use bisacodyl as a second line medication for us because we find that it produces more frequent bowel movements that are smaller. And when we're trying to achieve, larger bowel movements less frequently, the bisacodyl might not be as helpful. And then what are some strategies when doing these enemas and these flushes? Well, you're going to have to play around with it, right? It's titration. Titration throughout the bowel management week and even beyond the bowel management week can be necessary. And that kind of speaks to the 96 hours of nursing care that Marc referred to in our first slide. It's not a one and done thing. The flush is going to need to empty that colon every day. We're going to get those x-rays every day. If we find that they're still accumulating stool, we're going to increase our flush. If we find that they have a clean colon, but they're soiling a little bit, we might go down on our flush. And then if we find that they're very clean and they're not stooling, we know that we've kind of hit the sweet spot, hit the mark there. We might make adjustments to the base volume of saline. We might just bump up the base volume of saline. But usually,
and a quick question for you, Julie. Are these regimes then continued throughout the life of the patient, or there is a time when they don't need to do this anymore? What is the usual outcome?
Yeah, that's a great question. I think it certainly depends on the diagnosis, right? On why they're using an enema or why they're using a flush. We know that people that want to do enemas their whole life, if it's something we feel like they're going to constantly need some kind of mechanical option, we might move on to a Malone, because a Malone is something that an older child can do to themselves more easily.
Got it. Thank you very much.
It'll depend on the diagnosis, and we'll talk about some of the case studies at the end. We'll allude to whether or not that we anticipated they would be able to get off of it. Sometimes when we have those dilated colons, it's a matter of resetting the colon, training it to process stool in a much more efficient way. And sometimes when that is done for a period of time, 6 months or more, you might be able to wean off of whatever option we were choosing for you once you've reset the colon and retrained it to think.
Got it. A quick question. I'm sorry, I'm interrupting you. Casey says someone who gets obstruction from adhesions due to abdominal surgeries, how is that addressed? Is this someone who is treated with a bile acid sequestrant, sequestrants for bile acid diarrhea?
I don't know the answer to that question. I'm going to see if Katie does. Katie, if you don't, I don't know if the adhesions would be surgically, if there would be a surgical intervention to reduce the adhesions.
I think to a point, I think you consult with a colorectal surgeon to find out if the adhesions are something that you can address surgically. I know that at a certain point, multiple interventions in the abdomen can lead to additional adhesions. So you don't want to continue to do abdominal surgery after abdominal surgery. If the adhesions are causing some blockages, some of that can be overcome, I think, with some of the strategies that we're discussing. I'm not as familiar with the bile regimen that was posed in the question. So that's not something that we're going to discuss today. But I think the adhesions is something I would consult first with a surgeon and then find out if it's something that we can overcome by using either mechanical or medication strategies.
Got it. Thank you.
That's great. So then just the final little strategies here for the enema and flush. Patients have to be comfortable, right? If they're not comfortable, they're going to quit. And we find that with families. So we really want to make sure we go back to our goals and we're all on the same page, but then try and help them find comfort. Some amount of cramping is normal with a flush, but it has to be tolerable for the patient. And most importantly, we tell our family the cramping should subside after the flush and the sit and the expulsion is complete. Then there shouldn't be cramping. Main things we tell people to do are slow down the rate at which they're infusing it. If they've got that roller clamp open all the way and it's just flowing in there with cold water, it's going to cause them to cramp. So slow it down, warm it up, maybe use baby soap if the glycerin's really an irritant. If they're nauseous or they're vomiting, we definitely want to slow it down, warm it up a little bit. We might change the stimulant. We might change the timing of the flush, right? We don't want them to do this right before or right after a meal. It might be a little too much for the belly. And then if they're complaining of gas, we'll consider changing the stimulant. So we're always willing to work with people based on their tolerance and the effects and the side effects. We want to make sure they're comfortable so they stick with it. And now Katie's going to talk to you about medication programs.
Yes, so I'm going to talk to you a little bit about the medications that we use in our program. Again, and similar to the mechanical program, our goal with medications is to achieve 1 to 2 voluntary bowel movements a day. We want to effectively empty the colon with these bowel movements. And at the end of the day, we want the patient to have no soiling. We want them to be socially continent. We want them to be in clean underwear. We want them to be able to do the things that all of their peers are able to do. You know, we want the parents to be able to go to the grocery store without concerns that they're going to have an accident there, to be able to go to the pool and enjoy themselves. So we want to make sure that the patient's doing well or can do well on these medications. That being said, I tell families that I can get most people clean on laxatives and that I can get their colon clean. I can empty the colon. But I think Julie's touched base a little on this already. The laxatives, we want to make sure that the patient's going to do well on them. And that's not going to happen if the patient's not also engaged and ready to do that. And then anatomically, if they're set up for success. So a lot of our younger patients will start out on medications because we're not super concerned about when they go to the bathroom because they're in diapers. And so it's not a big issue just yet. And so we'll usually start with laxatives. And then as the patients approach potty training age, when they have underlying diagnoses such as Hirschsprung's disease, anorectal malformations, these diagnoses that have a surgical component, a lot of times as they approach potty training age, they've never been continent for stool. So they have never had good bowel control. And then we have to do a temporary period of enemas or the mechanical program like Julie just described. After about 6 months, we're usually able to retrain the colon to recognize the signals. Retrain the colon to send those signals to the brain that like, hey, I'm empty now, and I'll be able to recognize when there's stool there, because in the past they've constantly had stool present in their colon, so they're not able to well differentiate between being clean versus having stool there and needing to go to the bathroom. But if you do enemas for a period of time, the colon is able to decompress and kind of reset. And then the patient's much more likely to do well on laxatives. And then we can transition them to this medication program.
I had no idea, Katie, that colon can be sort of retrained by keeping it empty, and so it learns to reset itself, and then when it distends again, our brain can recognize it. I didn't know
Yeah,
this.
I
Thank
think
you.
when people are chronically constipated, which happens with a lot of our patients, those signals that your colon sends to the brain to say there's stool here, your brain either learns to kind of ignore it, or your colon just stops sending it altogether because there's constantly stool there. And so it would just be on overload all the time. So these kids who suffer from chronic constipation, and adults as well, if you can give them a period of being clean and give them a break from this constant constipation, the colon can learn what it's supposed to feel like to be clean. And then when you reintroduce stool with the medication program, they do much better.
Got it. Thank you very much. Something new for me.
Yeah, so when we're going to start a laxative program, I explain to families that the laxatives we use are really good at preventing constipation, but they're very terrible at treating it. So you want to get an x-ray first and understand if their patient baseline has a stool burden. If they do, we're going to clean them out first with either a Miralax clean out or enemas from below, because we want to start with a fresh slate. And then we'll start them on laxatives, which can help propel the stool through the colon. But it has to have room for that stool to be able to travel. So you just have to get an x-ray first and make sure that you're starting with a clean slate. So our laxative program, similar to the mechanical program, is a little bit of trial and error. We're going to give our best guess on the starting dose for a patient, and we use their age and their weight, and then their history as far as their diagnosis, and then what diagnostic studies they've had to help guide us on coming up with an original dose. But once we've come up with that dose, we tell families there's going to be a lot of tweaking in order to customize it specific to that child and that patient. When we do laxatives, we tell families to give them around the same time every day for them to work their best. The laxatives that we use, which I'm going to go into, but we use Senna. It works about 12 hours after you give it. So I usually tell families to take it first thing in the morning or to take it at night right before bed so that they have a bowel movement in the morning upon waking up. So timing is important with these medications. And then we talk to the families about soiling can be due to both overflow or too much stimulation. So when a family is started on laxatives, they can tell us that they're experiencing accidents. But it doesn't mean a whole lot to us unless we get an x-ray to go along with that clinical description, because a patient can be having accidents because the medicine is not strong enough and they're not getting all the stool out at one time, or they can be having accidents because the medicine is too strong, and even after they get the stool out, that laxative is still causing contractions in the colon and making excess material come out. So that's important too.
Got it. A quick question. I think we kind of spoke about this a few times. Betsy may have joined now. Betsy, this question is answered a little bit earlier as well. Where does one get help for a 78-year-old gentleman with over 5 years of bowel incontinence? So I think this is more of a help for an adult. So can they reach out to you and then sorry, go ahead.
I think in certain instances, we're always happy to help people find appropriate providers. I think in somebody who's 78, we're not able to help at our specific center just yet. And we do have that transition program coming. But we'd probably start with a primary care doctor and then a referral to a local gastroenterologist.
Got it. Thank you.
So the laxative that we use at our center most often is Senna. This comes in the form of both liquids, tabs, and then also chocolate squares. Senna is a natural herbal medication that contains senicides, which are derived from the leaves of the Senna plant. They cause irritation to the lining of the bowel, which then causes increased peristalsis and/or contraction effect, which leads the stool to be evacuated from the colon. I explained to families that we do not use Miralax at our center because they work very differently. Miralax is an osmotic laxative and softens the stool by bringing water into the colon, which then makes the stool more watery and easier to pass, but it doesn't do anything to help propel the stool through the colon. Usually Miralax in our patients leads to more frequent, very loose bowel movements that are difficult to control, whereas the Senna causes those contractions of the colon, helping the stool to move through the colon. And then it's usually results in fewer, more consolidated bowel movements. But as a side effect, because Senna is pushing the stool faster through the colon faster than it typically would travel, as a side effect, it does become looser because the colon doesn't have as much time to absorb the water as it typically would. So while both medications produce looser stools, they work differently. And so we typically use Senna as our maintenance medication rather than Miralax. Also, before I move on, I want to just address the fact that a lot of families, as we're starting laxatives, will have questions. The most common concerns that we get are laxative or Senna burns, which have been reported in the literature. And this is when patients will get a burn on their bottom with stool. After a lot of research, we've found that this typically only occurs in patients who are currently in diapers and have a prolonged exposure to the stool, and usually only on high doses of Senna. So it's not a common finding. And it's usually more based on the exposure to the stool rather than the medication itself. So we can usually avoid that just based on the timing of the medication and administering it properly. The other common concern that we hear is whether or not patients will become dependent on the laxatives if they start using them regularly. And in our patient population, I explain to families that their child is already, quote unquote, dependent on assistance. They need help in order to empty their bowels. They're already not emptying well. And if we give them the help that they need, it doesn't make them more dependent on medication. It's just that we're helping them, or we're providing the help that their colon already needs. And if you take them off laxatives, if you give them laxatives for a certain amount of time, it doesn't then require them that they're going to need additional laxatives. We give them only the minimal dose that they need, but to help the patients empty those bowels effectively.
Katie, I would just add, for whatever reason, we just had a call. Mark and I were on the call with a 26-year-old who was reaching out to our Center for Help, who had surgery at our hospital as a child. She's an adult patient now, and she said ever since I left, the pediatric world, the only help she's ever been given is Miralax, right? They just tend to, a lot of times adult providers will just keep prescribing more and more Miralax and not understanding that they need more of a stimulant. So I think that's common in the adult population we see, is that they're just all on Miralax.
Okay, so this is how we kind of start our laxative programs. For the most part, a lot of our patients are on a dose of Senna around 2 milligrams per kilo. There's not really a max dose for Senna. We just increase based on tolerance. We'll have some patients who are on a very low dose and they're able to empty effectively. And then some of our older children, especially if they've had a history of dilation in their colon, they require a lot higher doses. So it's really just custom and patient dependent on what they can tolerate and what they need in order to empty their bowels. As I just said, the side effect of Senna, the number one side effect, is just that it's going to cause loose stools. And to combat that, most of our patients get started on water-soluble fiber. Water-soluble fiber helps absorb some of that excess water from the colon so that the stools can have more bulk. So if a patient is started on laxatives and then they start to have loose stools, sometimes the answer is adding some fiber so that we can absorb some of that water. But if you get an x-ray and the x-ray is clean and the stools are really loose, of course, you might need to come down on our dose on the laxative. And then if our patient is on a laxative and they're not having stool over a 24-hour period, then we'll do another clean out, typically with an enema because it's faster. But patients are also welcome to do a Miralax clean out if they prefer and they want to avoid the enemas. And then we'll go up on the dose of this laxative. Oh, I just also wanted to make the comment. We typically see a dose around 2 milligrams per kilo with our Senna, but I don't ever usually start above 60 milligrams. So if you have an adult-sized patient or a teenager coming into our center, we don't start at necessarily 2 milligrams per kilo. We'll start at 60 milligrams. So whichever is less is where we'll start.
Got it.
Some other stimulant products that we have discussions with families about include Dulcolax, which is bisacodyl. As Julie mentioned, we don't usually use this as a first-line treatment just because it does lead to more frequent smaller bowel movements as opposed to less frequent, like larger bowel movements. So we don't use it as a first-line agent, but sometimes if patients are not tolerating the Senna very well, we'll give Dulcolax a try. These other products here are listed are the enemas, which we usually, if you're on a medication program, we'll use them to help clean out and before we go up on a dose or before we begin medication, but we don't ever use laxatives and enemas typically at the same time.
A couple of questions to both of you, Julie and Katie. One question is, it's more on the adult side. Mary says, what about taking whole psyllium husks or psyllium husks? No sweetener for adults. I know you must drink a lot of water while taking the psyllium. Is there a danger of choking and too much stool bulking?
So actually, the next slide is going to talk about fiber.
Okay, excellent. And I'm going to ask one more question though. So Casey says, I read that Senna can lead to increase in serotonin and exacerbate mast cell symptoms. Is this true? And if so, is there a good alternative?
I haven't seen that at all.
I have not heard that.
I have not heard that either.
No, the biggest concern most people have with Senna is the literature findings that there were Senna burns on some children. And we did a study on that at Nationwide Children's in Columbus, Ohio. And it was only found to be true with kids who sat in the stool for a long period of time with a high volume of Senna, like Katie said, but never heard about the serotonin.
Got it. Thank you.
Mm-hmm.
Okay, so as I had mentioned, we do use water-soluble fiber to combat the side effect of Senna leading to loose stools. So water-soluble fiber works to extract some of that extra fluid from the colon so that the stools will have more bulk. These are the brands that we typically use. We use Metamucil, Citracel, and Pectin probably most often. A product that we're currently trying is Nana Flakes, which is just like dried out banana, to help some of our younger patients who have a harder time taking the flavored Metamucil and Citracel powders. So it comes in various forms, but these are the ones that we typically use the most. Fiber does work better when you split it up throughout the day. So we tell patients not to take fiber all at once in the morning, but to divide the dose either 2 or 3 times throughout the day so that it's constantly in their system and it does work better. So when we start fiber, we usually start around 2 grams twice a day, and different fibers like that, 2 grams amounts to different quantities depending on the fiber that you're using. But that's typically where we start, and then we titrate based on the consistency of the stools. There's not really a maximum dose. You're just trying to get the stool consistency to something that the patient can tolerate, but has enough form that the patient can control the bowel movement and make it to the bathroom in time. And then again, I just have there listed the typical types that we use. So I think to answer the person's question, yes, you can take too much fiber. If you take an excess amount, you can bulk your stool too much. But I think then you would just titrate down. It's really just a customized effect that you're going for. You just really want to find the consistency of their stool of the patient's stool that you're happy with.
Got it.
So we have to do a lot of education with our families on the difference between water insoluble and water soluble fibers, because it's confusing when you read labels and when you see advertisements. A lot of our patients will try Benefiber, Fiber One, these examples, and we have to explain to them that these types of fibers actually work more of a laxative. So they're going to help you go to the bathroom as opposed to help withdraw some of that fluid. So we want to actually avoid these fibers in those who are on a laxative. Also within the medication program is that when we need to address the needs for our patients who do experience hypermotility. So most patients are coming to our center do have constipation and are struggling with hypomotility, but we do have a subset of patients who are hypermotil, particularly after surgery. So for these patients, we typically address their hypermotility first with a constipating diet and then water-soluble fiber. these are pretty benign interventions that we can start on any patient, any age, without having too much concern. If their hypermotility persists, we then add loperamide, which is Imodium. That's our next agent of choice. And then after that, we use hyoscyamine, which is Levsin. If we can, we'll also introduce a small volume enema. And we use this typically at night so that the patient can be clean overnight and doesn't have stool coming out while they're sleeping, to try to avoid some additional medications. But again, this has to you have to work with the family to find out if this is something that they can be compliant with, because a lot of families are resistant to nightly enemas. If we have to go beyond Levsin and Imodium on this pathway, then we typically are consulting our gastroenterologist or our intestinal rehab specialist to get their assistance, because additional lab work and monitoring is needed for these additional medications. And then worst case scenario, if a patient has hypermotility and we're not able to get it controlled, we may need to discuss a surgical option of a stoma with them so that they can have a better quality of life. With a medication regimen, diet plays a much larger role than it does with a mechanical option. I think it's important in both pathways to discuss it with the family, but your diet is going to influence your bowel movements a lot more frequently and easily if you're taking medications as opposed to if you're cleaning the whole colon with a daily enema. So the patients who are on a laxative program, we're going to have that conversation as to what stools are going to cause a laxative effect and those that cause constipation. And so that families understand, even if they're taking medication and the medication is the right dose, if they have a day where they eat a lot of berries or a lot of things that are high in sugar, it's going to lead to additional bowel movements than they're used to.
And I think, Katie, did you mention about keeping their diet the same?
Oh, no, but yes, when someone comes to us for like a bowel management program, which is this week-long program, we try to keep their diet as close to what they typically take at home, just so that we can get a good sense of how well the medicine or the program is going to work for them even once they go home, which is sometimes harder to do because these patients are coming from all over and sometimes staying in hotels. And so takeout and or hotel food is much easier when you're there, but we want to try to keep it as close to replicating their home diet as possible.
Great. So that takes us through bowel management. We have some case studies if there's time. Dr. Drbeen will check in with you.
Totally fine. Let's do it.
You want to? Okay.
I am actually already so grateful to Dr. Marc Levitt and to both of you for bringing so much information that people may be able to get it when they go to your hospital, but to learn it from outside and then be able to make a decision is a very valuable thing. So please walk us through the case studies.
Great, I'd be happy to. I'll take you through the first case study here. I think it's important. So many of the comments and the questions have been about adult care, right? And we are a pediatric hospital, and we are pediatric care providers and a pediatric team. But the information that you're hearing here today is certainly something that you can use as a springboard to talk with your own internist or GI specialist or primary care doctor, with suggestions like, hey, you've been prescribing Miralax to me, and why can we not try a Senna? And could we try a Senna? We certainly don't want you to go prescribing to yourself, even though they're over-the-counter medications. You should always consult with your own provider first and make sure, because we don't know what other things are going on with your health that would affect whether or not it's safe for you to take these medicines. But certainly these are great talking points for you to have with your own provider and see if there's some suggestions we've made that you could take to them and see if they can work with you to provide that to you. So our first case is a patient with Hirschsprung's disease. This is a 4-year-old female with history of Hirschsprung's. She had a rectosigmoid transition zone, presenting for help with bowel management. She had medical history of developmentally delay. She was deaf and had impaired vision, and she had a Suave pull-through procedure. Her stooling pattern is that she has a bowel movement every 3 days with the help of a fleet enema. She's had 2 episodes of enterocolitis post pull-through, and she does not do irrigations. She complains of vomiting, early satiety, and urinary tract infections. So looking at her right away, with her past surgical history, having a Suave type procedure for her Hirschsprung's disease, we're going to ask ourselves, could there potentially be a cuff there? Because we know that that is a complication that is not uncommon, but it can happen with a Suave procedure. So looking at her under an exam under anesthesia so that we don't traumatize her further. Her dentate line was intact. That was excellent. Her sphincters were intact. She did not have any retained cuff. She had a normal biopsy. There were ganglion cells present. There were no hypertrophic nerves present, which we know we see with Hirschsprung's disease. If there's a transition zone left behind. She had a contrast enema, and we do use contrast enemas here. We do not use barium enemas. Contrasts are much safer. And we did notice some distal dilation to her colon. So reading all this, do you anticipate good potential for bowel control for her? She is a Hirschsprung's patient. So what are we looking at there? Well, you remember we're looking at her dentate line and it's intact. We're looking at her sphincters, they're intact. Her bad bowel's been removed and she's got only good bowel left. So we anticipate good bowel control for her. Her contrast enema was overall, she was mildly dilated there. So you can see quite obviously, but she has no cuff. And so we chose to start her on enemas. And remember, this is a 4-year-old visually impaired, hearing impaired. Would you start the laxatives, the enemas, the ileostomy? We went ahead and started her with enemas. The family was motivated to get her clean. They really wanted to help her be clean despite her other impairments. Summary of her week, she started out at 400 milliliters of saline as her base solution. Her stimulant was 20 mLs of glycerin. And her regimen, the strength of that was increased based on what we found on x-rays. She ended up after the week of bowel management, the base solution stayed the same, but the glycerin was bumped up to 30 and Castile soap was added in as well. And she was tolerating those enemas well. You can see the x-ray shows some stool accumulation, but for the most part, she did much better when we bumped her up. And then what would your long-term plan be for this patient? So she was doing well on enemas. What would you advise? Would you keep her on the enemas? Would you move her over to laxatives? Would you give her a Malone? Do you think she needs Botox? Would you move to an ileostomy? Clearly, we achieve continence with the enemas, so we don't want to go to the ileostomy. We might consider a Malone for this patient. With her hearing and vision difficulties, it might be easier for her family to clean her colon out with a Malone, with an antegrade option, rather than trying to go through the enemas every day with her. If things went great with that, we might even try a laxative trial, remembering that that does not offer the predictability that a flush does. So they might choose to have the predictability of a flush through her Malone. So Botox we would use as needed. And Botox we use to keep the internal sphincters relaxing and for internal sphincter echolalia. And they will use it, the surgeons will also use it for a child that withholds on their external sphincters. So we have kids that are withholders and they hold on and squeeze their external sphincters. And sometimes we use Botox for those external sphincters to relax them. But for kids who have internal sphincter echolalia, we also use Botox. So that might be a consideration for her if that presented as a problem. For this child, it was not.
So Botox can go for the external sphincter or internal sphincter?
The internal.
Botox for the internal sphincter echolalia. If we have a child who just has withholding, it can be used on the external sphincters.
Got it.
And then case number 2, Katie can take you through an ARM patient. You have to remember really hard about what you learned previously.
So a 3-year-old male comes to your clinic with an unknown type of anorectal malformation in his history. He has a normal spine and a normal sacrum. You gather a contrast enema, which doesn't show any evidence of stenosis or obstruction. and you do an exam under anesthesia, which shows that his anus passes a Hagar size dilator at a size 16 without difficulty. The position of his anus is well centered, and there's no evidence of strictures or prolapse. In his surgical history, you see that he had a colostomy in the past, as well as an exploratory laparotomy with partial colectomy, an anoplasty, and then last a colostomy takedown. The family is coming to you because they're struggling with frequent diaper changes, smearing of stool, and skin breakdown. So with the anorectal malformations, we're going to look at the type of malformation, which were not positive, the spine, which is normal, and the sacrum, which is normal, which means that this patient probably has a good potential for continence down the road, but we have to decide what's best to do for them now. So as far as a mechanical or a laxative medication program to start, because the child is 3 and because the family is coming to you with a lot of concerns that they've had incontinence and fecal swelling and constipation for a long period of time, we started this patient on rectal enemas. So initially the patient was placed on 400 mLs of normal saline and then 20 mLs of glycerin, which is our irritant, if you remember from before. Over the next several days, the patient's stool burden started to go down, and the number of accidents also started to decrease. So after I think 2 days, the patient then started to have accident-free days for the remainder of their week with bowel management. So we get the patient clean with the enemas, and then we have to talk about what's the long-term plan. So for this patient, for right now, we're going to continue for rectal enemas, but we'll discuss with the family that a laxative trial is probably in his future. So we'll probably do the rectal enemas for approximately 6 months. And then if the family is ready and willing, then we'll try the laxative trial and try to put him on medications. That being said, a lot of our patients get on the enemas, and which Julie briefly mentioned, and then they decide that they don't want to start the medicine right away because in their experience with the medicine, they've had side effects like cramping, and the enemas offer that predictability and reliability that they've become accustomed to, and they really like that part. So not every family wants to switch back to medicine right away, but usually after 6 months, we can offer that as an option to the family that if they want to try laxatives, then we can try that. If for some reason he didn't do well on laxatives, then we would talk to the family about an antegrade option. If they wanted to do enemas more long-term, then an antegrade option might make it easier for the family to administer those enemas on a daily basis.
So this is one with functional constipation, and it's a 4-year-old again with no surgical history, and they've experienced functional constipation since birth, and that's not uncommon, right? We see so many patients with functional constipation. First thing we want to do is grab that contrast enema, and it did show us that the anatomy was normal. However, the patient did retain their contrast, their colonic contrast on the post-evacuation image. So when we got an image after the evacuation of the contrast enema, we could see that there was still a lot of contrast left in there. So they're holding on to things, right? Otherwise, it was normal, though, in its anatomy. Anal rectal manometry was done on this patient, something that you may or may not have availability to do, but it is nice when we do it. We were able to find that the child did have a rare presence, so that's normal, and Hirschberg's disease was able to be ruled out by that. We saw them in bowel management on day 1. They had a mild stool burden. We started a rectal enema based on this x-ray. There was ascending and transverse colon that appeared to be better, but there was a lot of formed stool in the descending and sigmoid colon. The rectum looked okay. We started them on a rectal enema with 400 of normal saline and 20 of glycerin. And then days 2 through 4, the stool within the rectum and the ascending colon was increasing compared to yesterday's exam. They had some streaking, some smears. They had some difficulty administering the enemas. Mom voiced a lot of concern. She said the child screamed and melted down for 2 hours prior to getting their treatment. We encouraged her to stay positive, and we gave her reinforcement and things to do to help with the sit time. It's all about whether or not you can get these children to cooperate. And if you can, great. And if you can't, you got to think about something else, because it's only as good as the child who's involved with you. But this one was able to get some advice from us on how to help sit and tolerate it. Continued on the regimen of 400 of saline and 20 of glycerin. And day 5, the stool burden was getting much better. Stool clearance was coming out. There was only mild amount of stool left. They weren't having accidents. The administration of the enema, mom said, was improved somewhat. She said the child was complaining still of pain. So there was a decrease there from the glycerin, and added some Castile in, which is a little gentler for the child. And mom can continue to complain of pain on withdrawal. So we discussed some techniques and tips and continue to address their psychological concerns, because this was a patient that was factoring in a lot to the success of the treatment. On day 6 through 8, the belly was looking more normal. The Castile soap was changed to baby soap to even try and be even gentler. And the pain improved over 6 to 8 days, and they were sent home on this regimen. Follow-up. Parents reported continued anxiety with the enemas, so we transitioned this patient to laxative therapy. And with that transition of laxative therapy, mom said that her child was thriving, they weren't having accidents, and she felt like they were getting their child back. So how great is that? No surgical exploration or options were needed at this time, and we didn't plan for any in the future. So goals for this patient were no enemas halfway through the week and then after. And so we had to be willing to pivot and change our plans based on what they wanted. And so that's just important to remember, that even though you think things are going to work out, if they're not working out for the patient, you got to be willing to pivot and turn. But did okay with there. A lot of questions have been asked today for the providers. There's a lot of good resources here. Mark, this first book on the far left that's kind of a burgundy or red color, this is kind of what we call our Bible for bowel management. Our nurse practitioners, our physician assistants, and our nurses use this quite heavily. And it's a nice book because it's broken down by diagnosis. So it'll say like Hirschsprung's disease, and then give you the different scenarios for that patient. It even talks about a patient with great psychosocial needs, things like that. There's a myth chapter on children with bad dentate lines and where we ever to overcome that. These are just some great resources that are available online if you're interested in learning more. And then there's 2 books here that are very surgically focused, which are also very helpful for the providers. And then there is a consortium that is only open to providers. For the parents on the call, I apologize. There might be some resource material on this website, but this is a provider website. It's a consortium that we have joined. Dr. Levitt, Marc, was responsible in co-founding this consortium, and it is for all these hospitals that are trying to work with children and help kids with colorectal conditions to put their heads together and think about what's working and report on those findings. We put our data into their database so that we can all learn from each other in live time. And that's what it's all about, right? That's why we're here today. We're not here to do a commercial for ourselves or say, come see us. We're here to say, how can we help everyone everywhere be better at caring for these patients? Because that's the only way that things are going to be great. And then we just like to acknowledge our team. They're absolutely outstanding. And that starts with the top, with our leadership of Marc Levitt and Andrea Badillo, our surgeons, and funnels all the way down to the people that pick up the phones and help our patients out when they call our center. And we are nothing without them. So that is it for our PowerPoint. If you have more questions, or you trying to stop to share.
So thank you so very much. This was such a great round. After Dr. Levitt's, Marc's discussions, this was a great closing structure added to that. So thank you very much to both of you for your time and for the insights. Let me see if there are any questions that I can quickly ask. Otherwise, we'll break for today.
Yeah, we hope it met your needs.
So there's a question from Ashish. He says, do we have some neurostimulants also, like as discussed, started with neurological things? Are there any neurostimulants for bowel management?
Do you mean uh, I don't know about like sacral nerve stimulation or?
I don't know.
Oh,
Maybe.
we have done in the past. Dr. Levitt, Marc has done. He had a partner once that did a lot of work with sacral nerve stimulation for bowels. It's not something we've been doing here in DC much, if at all. But
Got it.
it is another adjunct therapy, right? There's that as well as the TENS, the transcutaneous stimulation. But
Got it.
we're not doing either of those right now. We're pretty successful with what we're using. Doesn't mean we can fix everyone every time, but there are providers who are doing more of the sacral nerve stimulation. We just found
Got
more problems than we got positive production from.
Got it. Got it. So Ashish clarified that constipation due to neurological problems.
Oh, okay.
So I think we like a lot of our like spinal patients, I think have like neurogenic bowel, neurogenic bladder, and we see a lot of those. And we do treat them very similarly in that we offer both mechanical options and laxatives, but less laxatives just because there is a lot of nerve issues and sphincter problems. So usually those patients are more dependent on a mechanical option. Obviously, each patient is different, and we have to customize the care to them. And from a surgical aspect, normally for those patients, if we're doing surgery, it's to give them an antegrade option for like a Malone or a sacostomy, so that they can do those flushes long term.
Got it. Thank you. One last question. Blues Lover says, what about over the counter probiotics? So I would extend this question that in your practice, do you use probiotics and prebiotics like substances or
Not typically. It's not something that we recommend as like a routine medication that we put on for a lot of our patients. A few of our patients are taking probiotics. It's usually more of our hypermotility patients who experience some like bacterial overgrowth. And with those, we're typically seeing them hand in hand with our gastroenterologist.
Got it.
You know,
Cool.
we'd be
So,
remiss too in mentioning and not mentioning, because we didn't discuss it at all on this, and I'm sorry that we didn't, but pelvic floor physiotherapy is another adjunct therapy that's very beneficial and useful for our patient populations.
got it. So with this, thank you so very much. We spent about 1.5 hour or lesser, little lesser, but thank you for your time. Thank you for the insights. And not only this is interesting that not only this is useful for the physicians and providers, this is actually very valuable information for the patients and the patients' families as well. So thank you for your contributions.
Thank you for helping these children, everybody out there.
Yeah. So with this, Cool Beans, thank you very much. I would see you this evening with a patient interview at 6 p.m. Pacific time. See you then. Thank you very much. Bye-bye for now.